Thank you very much, Mr. Pielsecker, and thank you all for coming. I'm really honored to have all three groups here coming together, and the topic I'm going to talk about is minimally invasive therapies for localized prostate cancer. It's basically I'll give an update. I was asked initially to give a bit of a talk on one of the new therapies. I guess somebody saw it on, Glenn may have seen it on CTV, and I think it may be on YouTube anyway, but I'll describe some of that. That's only one of several things that we're doing, and there are other groups are doing exactly the same thing, are trying to basically solve this problem with prostate cancer, piece by piece, basically a big puzzle, piece by piece. And I'm going to give you just one aspect of that, and that's in the minimally invasive side of things. At the end, I think I will have some time. I'll talk a little bit about robotic surgery. Everybody wants to hear about robotic surgery as well, so I'll talk a little bit about that. I realize most of you have been touched by prostate cancer, and some of you had different treatments, may have had surgery, may have radiation, and some may have been very successful, others have not. And I'm actually focusing mostly on the parts that, for example, radiation, people who have failed radiation, there are some aspects of that, and then alternatives to surgery and to radiation. I'm a surgeon. I do a lot of radical prostatectomies, I do a lot of surgeries, but I also am very interested in alternative therapies. Now, when I say alternative therapies, I mean not so much drugs or herbal medicine or things like that, but mainly newer ways to target the prostate with maybe different types of energies, with different x-rays and so forth. So I'm going to talk a bit about cryoablation or cryosurgery, about HIFU, high intensity focused ultrasound. Some of you may have encountered this. So that's the way that is, high intensity focused ultrasound. Brachytherapy, I've already spoken to a couple of gentlemen here who have had brachytherapy with seed implants. A little bit of an update on that. Interstitial laser ablation using the lasers, different lasers that hit right into the prostate. And the new kid on the block sort of is the intraurethral ablation, which is the thing that we're currently working on. And as I said, if I have time, I will talk a little bit about robotics. So as far as most of these treatment goes, it could either be used as primary treatment, which is kind of first-hand before any other therapies when you're first diagnosed, or they could be salvaged, meaning, for example, if radiation has already failed, then what can we do to salvage the situation? That's why I call it salvage therapy. So kind of like second-line therapy. So, and then for each of those, the primary therapy, it could be a whole gland, which is the whole prostate. This is traditionally we attack the whole prostate, but some of the new theories now, or newer things, are actually targeting so-called specific areas, or so-called focal therapy. So instead of the whole prostate, we would target maybe specific areas if we know that those are the areas that we wanted to treat. Now, I got to tell you that this emphasize that this is in fact very investigational at the moment. So-called focal therapy is not the standard, is not accepted yet. There are numerous criteria that have to be satisfied before one can actually or should do so-called focal therapy, because we know that prostate cancer is what we call multifocal, meaning that the cancer is not only in one location but usually in multiple areas, and we really want to be sure that we're targeting everywhere that we think needs to be treated. So focal therapy is still so-called investigational at the moment. So firstly, I'm going to talk about cryosurgery. For each one, I'm going to give a little bit of a history of how it developed, what's going on, what's being done, what the results are, and where we go from there. Okay, so cryosurgery and how it works and the current status, as I say. So it started actually back in the 1960s. Cryosurgery is freezing the prostate. Cryo is freezing. or cold. Now, this here, in 1960, what they did were, there was basically an incision being made in here, down between the rectum and the scrotum here, and the surgeon would actually expose the prostate and then actually feel it with his or her hand, which you think is kind of crude right now. Imagine if you put your finger in the middle of winter, stick your finger on a cold lamppost or something. Your hand's going to freeze, or finger will freeze on that. As a kid, they'll stick their tongue on it and they'll get frozen, right? So remember that. So this is exactly the same idea, but they freeze the prostate, but the hand or the finger feels how cold it is. But when they make this incision here, it's pretty close to the rectum, which is right behind there, pretty close to the rest of the urethra. Plus, the fact that the machine was years ago, the machinery that they used, they were extremely crude. So there were a lot of complications. They didn't know how cold it was, how much freezing. There was very little control where the freezing would take place. So as you can imagine, that was not exactly very precise. And so as you can say here, so it was abandoned. The procedure was basically abandoned back in the 60s and 70s because of high complication rates, mainly with the damage to the rectum and so forth. So now there was a kind of a renaissance or resurgence in around the late 1980s for cryosurgery, and there are three things basically. There are better equipment, so cryogenics, different ways to do that, different material. There's so-called percutaneous instrumentation, which goes through the skin, and transrectal ultrasound. And that's initially some of these were designed for other uses, but they were put together and kind of basically had kind of like a perfect storm, and it became a useful technique. And this was in the New York Times, 1992. It says, if fire fails against cancer, try ice. So here's the so-called percutaneous technique. Initially, as I was saying, it was used for something else. They started putting tubes directly into the kidney for kidney stone surgery. But we can do exactly the same by putting tubes right into the prostate area and then introducing the newer so-called cryogenics. And then the other is the ultrasound machine, which goes through the rectum, and you can see the prostate much better than the surgeon can actually feel, because when you have a little opening in the rectum and just feeling, you're basically looking at just one aspect of, rather than the entire prostate. So here's the transrectal, just a picture of transrectal ultrasound. But this is for a biopsy. Some of you, I think most of you, men anyway, have had the, I was going to say the pleasure, but I guess that's not quite the right word, but had the, of having had a prostate biopsy, but that's how it's done. This is a three-dimensional ultrasound instead of two-dimensional. It's the three-dimensional ultrasound. It's one of the special programs that I have had the fortune of working with some of my colleagues who have developed programs on three-dimensional ultrasound, which I'll show you a bit of that too. So you can position what you want, and in this case we're putting the cryosurgery needle in the correct location rather than having it go off-site somewhere. So here's the cryosurgery. This is the older machines, and even this was an improvement from the ones from the 1960s. But this uses liquid nitrogen, but then the newer ones use argon. But you can see it's much more compact and quite slick. This is the rectal area, the rectum down there, the ultrasound machine, and the needles are put directly into the rectum. As you can see, the probes, which used to be much bigger, now are much smaller and much more refined, and you can actually be much more precise in putting in the needles exactly where you want. So in targeting the prostate, location is the key. You don't want to go into the wrong spot for it. So cryosurgery is still being done. It's done under general anesthesia or spinal anesthetic. It can be done as an outpatient procedure, 2 to 3 hours. Now, how does it work? Well, it relies on very rapid freezing from basically room temperature to the nadir is the lowest point of about minus 180 degrees. and it does that very quickly in a few seconds. And the end temperature is minus 40 degrees. And then the key is to slowly thaw that the frozen, basically a big hunk of frozen ice. The whole prostate is frozen, like a big popsicle, and it gets frozen, and then slowly thaw it, and then refreeze it again very quickly. The whole idea is to disrupt all the cells, all the membranes, and all the blood vessels, and destroy as many of those structures as possible. And in this process, freezing and then thawing, within each cell, each cancer cell, the water from the cells are precipitated into ice, and then the salt material is kind of set into a different compartment. And I won't get into details, but it causes a lot of other problems, biochemical problems, and how things work, the so-called metabolic problems, as well as the structural problems. So that's the whole idea, is to destroy the cells, destroy the tissue. Now we have so this is a picture of that here. The ultrasound machine, these are needles going, as you can see, going through the side. Here's the prostate. There's a tube in the middle. You don't want to freeze the urethra. So there's a warming device that goes through the urethra to protect the urethra a bit there, so that doesn't get frozen. And of course, the danger is to freezing other areas too much. So protecting the rectum is one thing, protecting urethra, as I mentioned, and we also put temperature probes in different locations to guide exactly how much the freezing has taken place. All right, so there are different areas that. Now, I mentioned the three-dimensional ultrasound. As I said, I have had the privilege of working with one of my colleagues, Dr. Aaron Fenster, who's a biophysicist who designed the three-dimensional ultrasound systems that actually is adopted around the world now. Most places use his sort of system to reconstruct. Instead of a two-dimensional view, you can do three-dimensional views. So basically, one way, the other way, and then the third way is looking directly straight through on the side. So I'll show you in a minute here. The red is, see, if this is a prostate, you want to go in, you can actually direct it. You think you're directing correctly on one plane, but in fact, it could be off. But you really here, in this case, you want to kind of splay it off to cover this side, so the yellow would be the correct angle. So on the side, you think that you're okay, but this is kind of one way of safeguarding where you put the right needles for cryosurgery. The same technology is used for other things as well. We use that for putting seeds for needles, for seeds, and other like interstitial lasers and so forth. So the same techniques, and even doing biopsies. In fact, that's for the prostate biopsy. If there's a small cancer that's hard to find and so forth, this is a very, very useful technique in finding out, getting more accurate targeting.